ECG. It's often pronounced EKG because it's easier to tell the difference between EKG than EEG and ECG. We're talking about the brain, electrical activity, or the heart. In fact, we'll be doing ECGs in lab today. All right, so we've got 2 machines out, and that's the only thing we're doing in lab. The rest of the time is for you to work on the physiograph, which I have worked today. So I was going to have it due on Tuesday, but I'm having it due on Thursday. So if you guys have issues with it, we can talk about it on Tuesday. Okay? And time for that to I just so that we wouldn't have time to work on it otherwise. So we look at the vagus nerve and sympathetic nerve innervating the autorhythmic cell. We looked at the action potential for those components. And so if I were to diagram this up on the board, you would understand whether we were looking at autorhythmic or contractile, right? Thank you. And so what's the channel that we find here? What ion enters the autorhythmic cells to create that depolarization? No? Sodium. Okay. Sodium is coming in here, and then calcium joins it. Okay. This entire area is due to sodium. Okay. And what's the name of that channel? Funny channel. Okay. So this is a funny channel. And we're in the autorhythmic cells. Of either the sinoatrial node or the atrioventricular node. Okay. And what do we call this calcium channel? We have 3 names for calcium channels. We have fast or long lasting, same thing. Slow and transient. Okay. So these would be the transient. And these 2 channels are producing what type of potential? A graded potential. Right? Remember, these particular cells do not demonstrate any resting membrane potential. You don't remember what the characteristics are for opening, the type of channel that opens for the funny channel? Why do we call them a funny channel? All right, so they open, they're voltage gated, but they open with a negative when we reach a more negative rather than when we reach a more positive. All right, so they have a negative voltage that they respond to. But they're also funny because they have 2 components that cause them to open. This is the voltage gated, all right? Most voltage gated are action potentials. So in this case, our voltage gated is a graded potential because we can change the grade, we can change how steep, how rapidly or slowly that graded potential increases. And that's usually a characteristic of a action potential. I mean, that's usually the characteristic of a graded potential, meaning it can be more positive or less positive or even negative. And so we can change whether this graded potential gains positive ions at a faster rate or whether this graded potential gains positive ions at a slower rate. So it's graded. Whereas action potentials immediately gain or repolarize the same amount every time. So even though it's voltage gated, it has the characteristics of a graded potential. And typically what causes a graded potential to form? A ligand gated. Does this open with chemicals? Yes. What's the chemical that causes this channel to open or to even open more early? Cyclic AMP. All right, so it's also ligand gated using cyclic AMP. All right. So both the negative charge and the cyclic AMP causes this channel to open, and the cyclic AMP can even change the negative charge at which it opens. So the more cyclic AMP we have there. All right. So sympathetic nervous system changes which component of our action potential in the autorhythmic cell? Does it change the graded potential or does it change the action potential? The graded potential, okay? So, our first question, norepinephrine binds to the following G protein coupled receptors on the plasma membrane of autorhythmic cells. GPCR, if you forgot from the endocrine lecture, stands for G protein coupled receptor. What's another name for a G protein coupled receptor? Ionotropic or metabotropic? Metabotropic, good. So you're just in time. First question's up. Sorry for the delay in getting the lab report online, but I got my 56 applications ranked by 2 minutes to 12 today. They were due at 12, so I've got to do no, just one. Norepinephrine does bind to more than one of those receptors, but in the heart, it's just one. Norepinephrine will bind to the first three. For the heart, I just want you to choose one. Talk about the difference between one was in the lungs and one was in the heart, and bronchial dilators for the lungs, we use a different one in the heart, so that you're taking a bronchial dilator, it doesn't affect your heart rate as much, and it would be designed to provide same effect, but it also does beta one. Bronchodilators will only bind to one type of norepinephrine receptor, not the other. All right, while you're thinking about that, we'll do some more review with this one. So, what channel do we find in this region? Long-lasting or fast voltage-gated what? Calcium. Okay? So these are fast or long-lasting voltage-gated. We know they're voltage-gated because that's our action potential, right? Calcium channels. And then on the repolarization aspect, potassium, voltage-gated potassium. All right, so for all of our repolarization, whether we're looking at neurons or skeletal muscle or contractile cardiac cells or autorhythmic cardiac cells, that repolarization leg is always going to be voltage-gated potassium. Okay? The other ones might change around a bit depending on the cell that we're looking at. All right, so here is the pathway with the cytoatrial node autorhythmic cells. And so what ion is entering the most proximal of our atrial contractile cells via gap junctions from the cytoatrial node? What type of ion? Look at the diagram I have on the board. What is the ion that rushes into the cell to create the depolarization of action potential, and thus will move through the gap junction into the most proximal cells to spread that depolarization to the contractile cells as well? Calcium, okay? However, we're spreading then to the next cell, the contractile cell. When we look at the action potential for a contractile cell, what channel is that? That's a voltage-gated sodium, all right? Just like we see with neurons and skeletal muscle. So from that point on, from cell to cell to cell, the gap junctions are spreading primarily sodium ions, okay? I'm not saying there aren't going to be any calcium, because calcium does come into the cell, but the current spread from one cell to the next via gap junction is going to be primarily sodium. All right, so we're going to look at then how this change in electrical current is picked up by an electrocardiogram. And what we see when we do an electrocardiogram, remember how when I described what you're going to be doing with the Physiology and the frog heart? How the changes that are shown on the oscilloscope are not electrical current, but are contractile forces. So on the oscilloscope for the frog heart, when you see cardiac contractile tracing, this is not a change in action potential or a graded potential, all right? This is force of myocardial contraction. And the atria has less muscle, so it's not contracting with its greater force. And the ventricle has more muscle, so it's contracting with a greater force. And if you see a change, such as the ventricular contraction is going higher, then that's showing a greater force of contraction, because it's pulling down on that transducer more, all right? So this is showing contractile force. When we look at an ECG, we're back to electrical currents, but we're still not looking at membrane potential, okay? Because when this ECG is created, we're not sticking an electrode inside any cell and comparing the charge inside that cell to the fluid outside the cell. That's how we diagram, that's how we determine an action potential such as that. An electrode is actually placed inside the cell, and the number of charges inside the cell is compared to the number of charges in the fluid outside. For an ECG, if you've ever had one done, electrodes are placed on the surface of the skin, not inside the heart, okay, and not even inside your skin. And you can have 3 leads or 4 leads and the ground, 12 leads. And what's being done is a comparison of the current in the electrodes across the body to the changes that occur in the heart, okay? So it's a comparison of current in 2 different places, rather regions of the body, rather than specific current within a cell. And so for that reason, when we look at these deflections up and down, this is not depolarization and repolarization of a cell or even a region. So if you look at a different lead, this can even go the opposite direction. So what we're seeing here is a change in the current as it's being picked up on different regions of the body. So this whole deflection up and down is illustrating depolarization, all right? Now, when you look at, go back to that just a minute because I'm going to diagram it here on the board. So this first portion that we see on the ECG is identified as the P wave. And what we're seeing here is changes in electrical current due to ventricular contractile cells. So this first P wave is created by atrial depolarization. Not depolarization and repolarization, but just atrial depolarization, all right? In fact, we don't see a tracing for repolarization typically. Then we have the QRS wave, and that is ventricular depolarization. So as the current is moving through the contractile cells of the ventricle, it creates this change. So that's known as the QRS wave or interval. And that would be ventricular depolarization. And then the T wave is ventricular repolarization. Okay? Now, this is not a measurement of contractile force directly. So if we, by saying that this is atrial depolarization, as a result of atrial depolarization, the two atria are contracting, all right? But that's not what's being measured here. It's the electrical change that's being measured. As a result of that, the atria contract, okay? What we're measuring here is the electrical change in the ventricular muscles, indirectly, compared to the skin. But as a result of that depolarization, the ventricles contract. What would the ventricles be doing as a result of the T wave? So by the end of the T wave, the ventricles will have, this is repolarization. The ventricles will have, it also starts with the word R, the letter R, relaxed. Yeah, okay? So, this is called the PQ, or actually it's called the PR, but it starts here. So if we go from P wave to here, even though the R is up there, that's called the PR interval. And from here to here is often called the PR or PQ segment. So what's happening, and this is measured a long time, all right? So the longer it takes for something to happen between 2 points, it's going to be measured by a longer line along the graph. So what's happening between the end of the P wave and the beginning of the QRS wave? The P wave is atrial depolarization, and the QRS wave is ventricular depolarization. What's going on in the heart? So the P wave is created by the atria depolarizing. The QRS wave is created by the ventricles depolarizing and contracting as a result of that depolarization occurs. So what is taking place here? Draw a flat line. That's not a resting membrane potential. That's just showing we're not seeing a change in current activity in the heart. What's taking place between the P wave and the QRS wave? If I were to measure someone's ECG, and instead of looking like this, it looked like this, what's going on? Pardon? We skip the ventricular contraction. That's called an AV nodal block. So what's going on here? Instead of skipping it, let's just say it just took a really long time. So what's going on when we don't see anything up or down, any deflection upwards or downwards? Yes?
The time it takes for it to travel to the ventricle.
Exactly right. So from the end of the P wave depolarization, we have the AV node depolarizing, the AV bundle or bundle of His depolarizing. The current is traveling through the bundle branches and up the conduction myofibers or Purkinje fibers, and then that triggers the ventricular depolarization that we see as the QRS. So this segment here, if it's short, it's not taking very long to get through there. If it widens, so there's some disease process usually that's interfering with that conductance. Okay, but it takes so long that SA node may fire again before the ventricles ever do and we miss a beat.
Is that for both the PR and PQ?
Well, the PR would be longer, the PQ interval would be longer. The this is called the segment, but the interval would be longer as well, because the interval includes the P wave as well as the segment. So this is the atrial depolarizing, and then we see no current change because that's when it's actually traveling through the conduction current between the AV node and the muscle contractions. Now, we will look at a situation where the P wave is bigger.
So the PR segment is part of the PR interval.
Right.
Okay, so
Yeah,
just a piece.
this is the
Okay.
small p node, it doesn't include the atrial contraction. So what do you think is going on here when the P wave is larger? If this is a time segment and it takes longer for the current to go through? Huh? Not an SA nodal block, but there certainly is interference. We typically see this with a condition known as mitral stenosis. So what valve are we talking about when we say mitral? Left side or right side? Left side. Semilunar or atrioventricular? Atrioventricular. Stenosis means that the valve leaflets don't quite come together. They might be thickened or damaged by an infection, a bacterial infection. And so when they don't seal well together, then when the ventricles contract, instead of all the blood being forced out the aorta, the wrong valve actually, this is the AV valve, or these here, when they don't come close together, or there's a leakage, then when the ventricles contract, blood is pushed not just out the aorta, but up into the left atrium, where it just came from. So what's gonna happen to the size of the left atria if we're pushing blood back into it instead of out the aorta? It's gonna get bigger. And if it gets bigger, it's gonna take longer for the current to travel through it. And so when that happens, we see a larger P wave. Okay? So we kind of see reflections of what's going on in the heart, time-wise and so on, by what's occurring with our ECG. All right, so if the atria are contracting here, and the ventricles are contracting here, and relaxing here, what's occurring during this time? Filling of the atria and filling of the ventricles. Okay? So when we think of the heart's activity, we're going to talk about cardiac cycle later and a little bit later. So we have the heart is at rest, then the sinoatrial node fires, the atria depolarize and contract. That current spreads through the AV node down to the bundle branches, then the ventricles contract, and then the heart relaxes again. We have this kind of cycle. Okay? Atria contract, relax, ventricles contract, relax. Atria contract, relax, ventricles contract, relax. So they never contract at the same time. But during the flat straight segment here, between the C wave and the P wave, they're both relaxed. All right? And if they're both relaxed, what valves are open? The atrioventricular valves are open. The bicuspid and tricuspid valves are open. And so blood is flowing, the atria is relaxed, blood is flowing from the atria, it's returning to the heart under low pressure, and blood is flowing through the atrioventricular valves into the ventricles. So this period of time is known as ventricular filling. Okay, because that's when blood is passing through the atria into the ventricles, filling them up before they contract. So when you're visiting somebody in the hospital, you're seeing a little ECG on the machine beside their bed. You'll have a little better idea of what the heart is actually doing during those events. All right, so now I'm going to leave the ECG up on the board, erase these terms over here, and the pathology down at the bottom. And let's relate this to what's happening in the electrical current of the autorhythmic cells at the same time, okay? Even though the ECG is not a direct measurement of that, we can overlap it with what is actually happening in the heart. depolarization of the atrial cells? What event of the autorhythmic cells triggers the depolarization of the atrial contractile cells? So what do we have to do to the contractile cells to cause them to depolarize? One contractile cell's action potential is going to look like this, right? So what brings enough positive ions to the contractile cell to cause those sodium voltage-gated channels to open from the autorhythmic cell? So if we have an autorhythmic cell here, and it's connected by a gap junction to a contractile cell here, and when positive ions come into this cell, that's going to cause that event, right? So what's happening in the autorhythmic cell, we contain enough positive ions that they flow through the gap junctions to cause this contractile cell to do that. No?
I'm not sure now.
All right, so this is the contractile cell action potential, right? What does the autorhythmic cell look like? So what we have happening is we have our autorhythmic cell is depolarizing, right? Funny channels, and then funny channels and transient calcium channels. And then we reach a threshold potential, and our fast calcium channels open, so that's what causes this event. And so we see an action potential, flood of calcium comes out of the autorhythmic cells into the most proximal contractile cells. That triggers this event in the contractile cells that causes the depolarization of those cells. Okay? So it's the action potential of the autorhythmic cell that results in the action potential of the first atrial cells that starts the wave of current coming through. So right at this point, when this fires, this is what we see, the action potential of the autorhythmic cell. And it's that action potential that triggers the first action potentials of the atrial contractile cells. And then through the gap junctions, that spreads like a wave with these positive ions going. So in this next channel here, positive ions of sodium are going to spread to the next cell. Whereas these are calcium ions here, okay? But it's the reaching of the action potential of those autorhythmic cells that triggers the P wave. And then the rest of the depolarization of the P wave is due to this happening over and over from one cell to the next. All right, so then we repolarize, and I said that P wave repolarization is not shown up on here. And then the entire time until we get to the next P wave, we're repeating the same thing. So flooding channels are open, and then transient channels are open, and then we trigger another action potential, and we see another P wave.
Those are autorhythmic cells.
These are the autorhythmic cells.
Those are triggering the P wave.
Correct.
Okay.
All right, and then usually, if the conduction system through the interventricular septum is working, that then passes through here, and that triggers the QRS wave in the ventricle. Okay? But it's the current from the P wave, current from the autorhythmic cells triggers the depolarization of the P wave. The depolarization of the P wave causes the current to travel through the AV node and the bundle branches, and that triggers the depolarization of the QRS waves. Okay, so it's all like a series of dominoes. So the first domino to fall is the action potential of the autorhythmic cells. The next domino to fall, the action potentials of the contractile cells. Next domino to fall, create action potentials in the conduction system from the atrium to the contractile, to the ventricles, and then we see that in the ventricles. Okay. So it seems like a lot's going on here, but during that entire time, the autorhythmic cells are doing their graded potential depolarization. So if this takes less time, what's gonna happen to the time gap between the T wave and the P wave? It's gonna get less, okay? Now you're ready for this question. The question says, which of the following occurs at, so looking at the ECG, the P wave is A, the top of the QRS wave is C, the T wave B, the T wave is C, and this gap is D. So the arrow is best matched up to A, B, C, or D. Not trying to make these tricky, so we'll do that. Does that help?
It would be the same thing as if you pointed before that,
Yeah.
too, like before the first.
Well,
Right.
in actuality, this entire, all of this, I could pick out any point up until here would be occurring after A, okay? But I've got this way over here, so this latter part here would be best matched to which letter? So A is going to be this, right? So then B and C would be all this area here. But as we're doing this portion here, we're gonna be way over towards here, because we're about ready to do the action potential again, okay? Well, without a resting membrane potential.
No.
Okay, all right, yeah, the ventricles are right.
Yeah.
I'm a little paranoid about you guys, and I'm thinking it's electrical part.
Yeah, it's starting to open up. So. Oh, number one.
So yes, let me put it.
Did you write it down?
Further ahead.
So if we have the T wave here,
Page 54.
the action potential occurs with the T wave here. Then it would be like that. Okay? So even during the QRS, the autorhythmic cells are forming their graded potentials. But I marked it over here. So we're more in line with that. Without actually telling you that the answer is D. So this is called the Einthoven triangle, and I have a little bit about it written up in your lab packet, but I'm not into the physics of it enough to explain it more than what I already have. So I don't expect you to understand it any more than that. We have 4 leads, 1 is a ground, and again, it depends on which one the machines are set up to read. So sometimes when you look at an ECG, they look like they're flipped. So the QRS wave, instead of going like this, goes like this. Okay, and it all depends on which lead is being read. So you'll have to be an RN, you can train to be an ECG tech and read those components, and you get a lot more training than I had. All right, but what I have on the board is what I want you to understand. Recognize that we're not measuring the actual difference in ions within the cell versus outside the cell. Okay, we're comparing the lead location to those components. All right, so let's look at some comparisons and pathologies. We talked about micro-stenosis comparison, so let's look at some other ones. And this is not enough to be trained to be an ECG tech, okay? So it's just enough if I show these examples on an exam or on a quiz that you can look for characteristics to identify what's going on. So, normal rhythm is, average heart rate is considered to be 70, okay, when we talk about cardiac output and so on. Mine is a little higher than that, it's probably 80 right now. When I wake up in the morning, it's like 78. My husband's is about 48 to 52. He's 66, my son is 28, and his is about the same, around 48 to 50, okay? I have no idea what Trump's is or what Obama's was, but I do remember that when the second Bush was president, he was proud of the fact that he was more of a runner. His heart rate was around 50 as well, even though he was past 50 himself. So heart rates are lowered typically by cardiac exercise. So the stronger you make the heart muscle, the fewer times it has to contract because it's stronger and it gets a greater volume out each time. So we'll reflect back on that when we get to cardiac output, okay? So sometimes an enlarged heart is considered enlarged physically, but it doesn't mean pathology if it's due to actual muscle and not to a weak heart that's enlarged and doesn't have the strength to contract. So although some of the numbers that we have up here are variable, there's different causes for that. So tachycardia is identified as a heart rate higher than 100. There may be a very good reason for that. If you're out for a run or swim, or you're at higher elevation, all right? Doesn't mean that you're sick, just because your heart is tachycardic, all right? 100 beats per minute, if you recall, is the heart rate that most hearts would be without the effect of acetylcholine. So normal parasympathetic system is our normal everyday functioning component of the nervous system, and it is a major factor that keeps our heart rate, slows down the SA node. Because the SA node, without any modification by the autonomic nervous system, would fire at about 100 beats per minute, okay? Bradycardia is typically less than 60. Although, again, for some people that would not be abnormal until it got down to less than 40. All right, so that's just variations. You don't have to know the difference between sinus. It has more to do with the silent atrial node. All right, on the atrial fibrillation, I don't know if you recall, but I believe I said when I was going through with the rate for the SA node and AV node and so on, that the contractile cells themselves can be autorhythmic. They will depolarize on their own. But it's much slower than the SA node, so they're generally overrun by the depolarization of the SA node. The contractile cells will depolarize in about 15 times a minute, but they're not connected, they're not organized. So you'll have a cell over here contract and a cell over here contract, and they just depolarize at their own time. And that results in a quivering, all right, of the muscle, not a wave of contraction. So when the atria is not, the SA node is not firing, then the atrial muscle cells, the atrial contractile cells, will fire on their own, but in an uncoordinated manner, and they'll just quiver. That is not life-threatening, at least not directly. And so, but what we see is the absence of a P wave. Okay? So with atrial fib, and that's the term for that uncontrolled depolarization resulting in uncontrolled or uncoordinated contraction. Atrial fibrillation, the blood is still going to return to the heart. The force is provided, the force for blood flow is provided by the ventricle contraction. So we just have kind of different cells contracting, and then we'll see a ventricular contraction, and the atrial will just contract. So we're still getting the ventricular force. All right? Question, Caitlin?
On your notes, the picture looks like upside down compared to
That, again, that was a different lead.
Oh, okay.
Yeah. So one of the characteristics of AFib, without that can be difficult, well, not difficult to check, but you may not be aware of without checking your pulse, is that atrial fibrillation can show up with extra beats, and you can have the ventricles contracting close together. Notice that this doesn't give much time for the ventricles to fill with blood. So if you're listening to the heart rate and counting heartbeats with the stethoscope at the heart itself, that's known as apical heart rate or apical pulse. And if you have AFib, that number is typically higher than when you feel the expansion of your pulse at your wrist. What causes you to feel a pulse at your wrist? Week after next, we'll look at blood pressure. So I'm feeling my radial pulse right now, and it's my radial artery expanding due to an increased volume of blood. And that increased volume of blood occurred when my left ventricle contracted and pushed about 70 mils of blood into my aorta, and that moves through as an expansion through over time through the arteries. So if I have a contraction here and I only pump out maybe 10 mils of blood, that's not going to be enough for me to feel an expansion at my radial artery. So I would have a higher apical pulse than my radial pulse. Okay? So you have to do this at the same time because there is variation. You can't listen to your heart and then 5 minutes later count your radial artery pulse because there are variations. So if you have an apical pulse, say of 72, and you have a radial pulse of 66, you had 6 extra beats at your heart that you did not have enough blood sent to your radial artery. Okay? You'll never see it the other way around. It's impossible to have more expansions of the radial artery than contractions of the heart. There's no way for that blood to get there to cause it to be expanded other than the heart contracting. Okay? So it's only possible to have fewer if we have contractions close together that don't allow for the ventricles to fill with blood and expand outward. Now, the blood's still going to move through the body, and as I said, a lot of times, most of the times, people have no symptoms, but other than this, and so there's often a public service announcement out on the radio about preventing strokes and checking for the difference in the apical pulse component here. Because over time, when there's a greater tendency for blood to settle in the heart and result in blood clots, which can then move to the brain for strokes or cause pulmonary embolisms in the lungs. So that's over time, usually over a decade or 2 decades of having AFib before you see a result like that, okay? Ventricular fibrillation, however, is much more serious. With ventricular fibrillation, we have no pressure created to move the blood out of the heart. So blood pressure is at 0, okay? We just have ventricular muscle quivering and nothing happening. No contractile force being created, just sitting there and doing this, okay? So blood's not coming in, blood's not going out. What's the purpose of a defibrillator? A shocking of the heart. I talked last night, I usually illustrate a teacher in a kindergarten class or maybe a class of 5th graders. Everybody's talking, nobody's listening. And so to get control over the class, the teacher blows a whistle really loud or does something to shock the class, and they all stop because they're surprised, and while this room is quiet, an attempt can be made to gather their attention, all right? So the purpose of a defibrillating current with paddles is to send such a strong current throughout the heart that every cell, all the SA nodal cells and AV nodal cells and all the contractile cells depolarize, all right? And then as they recover, the one that's going to recover first is usually the SA node. Because remember, it has a rate of 100. So the ventricular cells at a rate of 15 are still going to be recovering by the time the SA node does. And so it has the opportunity to gain control and get the other cells to contract in line. These 3 ones here are what I showed up earlier that are known as AV nodal block. So a complete block is when we have a P wave without an accompanying QRS wave. In between are degrees of variations on how wide a gap there might be between the P wave and the QRS. You don't have to identify the differences, all right, just recognize it as an AV nodal block. It's usually some disease process that decreases the time that it takes for the current to pass from the AV node to the ventricular contractile cells. In some of the physiology classes I've taught where we use a frog heart, that can be simulated by a frog heart. Remember, it has just one ventricle, two atrias, by taking a thin piece of thread and tying it between the two atria and the ventricle without completely shutting off the blood flow between the two, and that can cause that AV nodal delay by interfering with the conduction.
So you said the nodal blocks, just recognize them?
Yeah, you don't have to. Well, you don't have to identify the difference between first degree, second degree, or complete,
Well, we need to recognize.
but
that.
recognize it as a nodal block.
So what makes it a
So-
nodal block? Can you show me?
So here we have a P wave,
Uh-huh.
a P wave, a P wave, and a P wave with varying degrees of time
Okay.
with the resulting QRS. Okay? Here we have two P waves that have no QRS at all. So those are all nodal blocks where we have a P wave and it takes a long or very long time, or it never gets to the ventricle or the responding QRS. All right, with premature ventricular contraction, this can be caused by drugs. All right, it can be by drugs. I'm not talking about Oxycontin or something like that specifically. When my oldest son was two and a half, we were visiting. Well, we'd been to visit friends, and they were both doctors, but they had no kids, and she had a box of toys and a stethoscope. And so while my husband and I were talking with her husband, she was playing with Chris, and she looked up and apologized, interrupted our conversation, and said, "You've had Christopher's heart checked out, haven't you?" And I still at myself, and I never asked her why she even asked the question. I just said, "Yeah, he's had his doctor appointments," and I never said, "Why are you asking?" And then that summer, we were in Tennessee, spending the summer visiting my sister, and we took our kids to Six Flags, a couple hours away. And Chris had always, whenever he got a bath, he would turn blue around his mouth. And I just assumed he was cold. But this time he was trying to go to the bathroom, trying to have a bowel movement, and was straining, and he turned blue around the mouth as well. And I mentioned it to my sister. She'd been a pediatric heart transplant nurse down at Loma Linda. And so she said, "Well, I'll get my stethoscope out and check it when we get back home." And so she did, and she called me over to listen, and his heart was boom, 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 boom. I mean, it was just not ever regular. And a lot of times kids, when they're not getting enough oxygen because of heart issues, when they're playing, they'll just stop and squat. I'm not sure how that helped him out, but he'd never done any of that. But I called and made an appointment with his pediatrician for the next week when we got home. And it was canceled because I think the doctor's tires went flat or something. Anyway, so in the meantime, I had gone and looked up, so he was on medication because he had a cold. So I'd given him a pediatric, antihistamine or cold medication. And it took 3 hours of looking at the medical school library, and I found that Triminute could cause premature ventricular contractions. So like a good mom, I stopped giving it to him, and now you can't even buy it for kids. And by the time we actually got the doctor's appointment, because my sister was like, "You should get a 24-hour monitor," and his heart was fine. The doctor, I don't even know if he ran the ECG, says, "You're an RN, you just worry too much." And ever since, I was like, okay, is my kid going to be the one on the basketball court that collapses? And when he got to college, he was trying to get from Folsom Lake College to Sac City College in time for basketball practice because he was trying to make the team. And his blood pressure was always high because he didn't want to get a ticket, but he was driving fast. And so he failed the physical because his blood pressure was too high. And that's also when he figured out he couldn't drink caffeine, and because it made his blood pressure high, and he would get headaches during practice. So the team doctor said, "Well, before you can play, you have to go get checked out." So he went to get checked out, and the doctor everything was fine. The doctor was about to clear him, and he was looking through the notes. He goes, "Oh, I see here that you've been getting exercise-induced headaches. So I'm not going to clear you until you go get a stress test," which is is an echocardiogram on a treadmill. Anybody ever done that? Totally embarrassing if you're a female. So my father-in-law had one, but because he was older, they gave him drugs to induce a high heart rate and he didn't have to get up. So I specifically wore shorts and a running bra that didn't have any metal, so I could, you know, they put the electrodes on you and then they do an ECG and then you get up and you run and get back and they run the ECG and they don't want to take the electrodes on and off. So I'm all ready for this, I thought, and the guy says, no, you have to take everything off.
What?
Yeah, so I'm on the treadmill, just bouncing around with a, I mean, I did have a gown, but it's open in the back, and I'm like, really? So, yeah, so I've never gone back and had one of those done. Anyway, maybe it was just the tech. And so he checked out fine. So from the age of 2 to the age of 18, you know, I've been worried about his heart, and so came back fine. The next year, he's in college, and we get a call. Actually, a picture of him. I might have told you guys about this. We get a picture of him. He's in the emergency room with electrodes on his chest. So I call and I talk to his doctor. He says, "Don't worry. 21st century heart problems we treat with 21st century medicine." And I'm going, what? And he had fainted in his shower, and his roommate had driven him 15 minutes to the hospital. And so he said, yeah, I was thinking maybe he had a pulmonary embolism, so I ran a scan, and his hepatic veins were enlarged. So the hepatic veins are the last vessels to dump blood into the inferior vena cava from the liver before it gets to the heart. So if the hepatic veins are enlarged, that means blood is backed up from the right ventricle into the right atrium, which means, and back into the inferior vena cava, which means right side of ventricular heart failure. Anyway, I'm freaking out. My husband and I have been expecting this news ever since the kid was 2 years old. And so we drive to pick him up the next morning. Napa, the hospital up near Angwin, has $2,000 used from their patient rooms out over the Napa Valley. And pick him up, and he's holding his jaw, but it was his right side, not his left side. And the doctor checks him out. And I said, well, what about that enlarged hepatic veins from ER last night? He goes, I never saw anything about that, so let me check. So while he's gone, I'm asking Chris, so does your jaw hurt? And he said, no. He said, my throat hurts. He said, I had it checked out for strep throat on Tuesday. And I said, well, what did the doctors in the ER say? And he said, they never looked. Did you tell them about it? And he said, yeah, but they never checked it. So in the meantime, the guy that's checking him out comes back and says, radiologist never wrote anything on his chart, he's good to go. So we bring him home for the weekend, and every time the car stops, he has to open the door to spit. And they ask for a cup, so during the night he can spit. And I said, here's a towel, just let it drain. And he wouldn't let me look at his throat. So the next morning I did. I ended up taking him to Center General's ER, and they called in an ENT who took out 15 mils of pus from one of his tonsils. He had a tonsillar abscess. That was his whole issue. And then our insurance company wanted us to pay the bill at the previous hospital because it was the wrong diagnosis. It's like, I'm supposed to tell them that? But anyway, his heart apparently is fine, but it's just all those kind of things from the PVC. And like I said, they don't even know that that's not even prescribed for kids anymore. So different drugs, different irritables, medication can be given for this. Sometimes people have like an ectopic heartbeat. So they have an area of cells in their atria or their ventricle that fire faster than other areas and can cause the heart to fire faster. So they may go in there and just, it's called an ablation. A-B-L-A-T-I-O, and not that you need to write that down, but it's called an ablation, and they just kind of use a laser and basically burn it off from the inside. So there's, like I said, there can be various causes for this. Okay, notice what's different for the MI. You guys know what an MI is? It's a fancy word for heart attack. Infarction is part of the ventricular muscle tissue has died. Okay? So what we see here is it takes longer because of that dead tissue. It takes longer for the repolarization, so we have an elevated ST segment. So that image, our QRS wave, and then the S, so the S doesn't come all the way down, and the T wave is higher. That's known as an elevated ST segment. change to ECGs and heart attacks, okay? And then this one's a little small, it's shown flipped as well, but remember I said that enlarged P wave is caused by, in mitral stenosis, by an enlarged atrium that takes longer for the current to pass through. A little similar for the same reason as our elevated ST, but it's not dead tissue, it's just a larger chamber. And it takes longer for the current to pass through the left atrium, so the P wave is enlarged. Okay, so reviewing from Tuesday night, which of the following is the effect of acetylcholine binding to receptors on contractile cells of the ventricular myocardium? You ever played a game where you get a list of 20 or 28 things to do? And the very last thing is, very first thing is read all of the requirements. And the very last one is, don't do anything, just turn your paper in. So read this carefully. When you read the question, there's one word there that should tell you the answer immediately without reading any answer choices. Okay, Joyce, what's that word? Well, the word contractile, no. Ventricular. Why is that the key word? Anybody else? Why is the key word ventricular up there? Not contractile, but ventricular contractile. No? Yes. There are no receptors for acetylcholine on ventricular contractile cells, only on atrial contractile cells. So the vagus nerve will not change the force of contraction, as we'll see a little bit later, because it's not controlling the ventricles, whereas the norepinephrine can change rate and cause more calcium to be in the ventricle cells and change their force. So the acetylcholine only has an effect on the SA node, AV node, and atrial cells, the atrial contractile cells. But atrial contraction isn't that important anyway, so it's really not going to affect blood pressure or the rest of the function of the heart. Okay, so as soon as you see that term, then it doesn't matter what I write, because all your choices, none of them are going to be correct as far as anything as far. So this would be true for norepinephrine, okay? For norepinephrine on the SA node, this would be true for acetylcholine at the SA node. But none of those are true for acetylcholine at the ventricular system, okay? All right, so this is a good place to stop and take a break. When we come back, we'll look at cardiac cycle. We've already talked about it, all right? So we have a few new terms when we talk about cardiac cycle, but no new events. We're just going to look at them in the sequence of what happens and what are the pressure changes that open and close the valve, which we've already talked about. We're just going to do it in a more cohesive manner, okay? So come back in about 10 minutes, 20 till, and we'll look at cardiac